Good morning, everybody. Good morning. So I think you all know Helena Knapp, the Executive Director of the Greater New York Chamber of Commerce. I'm Mark Jaffe, the President. And Helena keeps it all together. We have some board members here. We have Howard Teach, the chairman of our board, and a prominent attorney in New York. We have George Hulse, who is the special advisor, president and CEO of Emblem Health, and he's also on our board of directors, and a fantastic asset to the Chamber of Commerce. Thank you, George. I think George also has his hands into the Korean American Chamber of Commerce. And I think we're going to the caucus this Albany. Commissioner, we like to go to Albany. We came up for the state of the state, and we're so privileged that you could come down and give us a little more details. I know that we also have, I believe, somebody from Cornell Weill here, one of the largest best practicing hospitals, almost 1,000 beds, and I believe you're part of my network, so thank you. And we have somebody here from Kansas. We have many people here, but we'll network later. So I want to thank you for coming down and telling us what's in this $256 billion budget. And of course, we all have concerns about our health care, our retirement, and I asked the commissioner to highlight some of those. It's very important to business owners because if you have people working for you, you need to provide them good wages, make sure they can afford housing, health care, and good education. And this budget is full of richness for the hardworking New Yorkers like us. So let's put our hands together for the New York State Commissioner of Health, McDonald.
Thank you for the warm invitation. It's great to be here. And great to be in Manhattan again today. Thanks so much. So let me just start. We'll chat a little bit. I'm going to talk about 20 minutes, then answer questions. So, but it is great to work with Governor Hochul. In case you're wondering what it's like to work with Governor Hochul, she's just a really nice person. I really enjoy working with her. Like, you know, it's rare to have someone who's so friendly, so smart, but actually genuinely cares about people. You know, what I really see from Governor Hochul is just want to help lift people out of poverty. And as a public health physician, I'm all in. Just want to let you know I'm all in, right? And I love this quote from her. Our future depends on the ability of every family to afford the essentials of life and our ability to protect the health and safety and security of our residents. And one of the things I tell the governor is every one of her budgets is a public health budget. If you look at the whole budget in its aggregate, what the state of New York's budget is about is really lifting people out of poverty, helping people find affordability, but really improving everyone's quality of life. And this is part of what makes it really easy to work for her. There's some things in the budget that are top line. So $260 billion, gosh, that's a ton of money. You know, and it's interesting to me, like, that's just a big number, right? It's down $10.3 billion from the federal government. That's 11.4% decrease. State operating funds up to $157.6 billion. In other words, that's what we're spending. I want you to grab onto that number for just a minute, $157.6 billion. That's how much the state is contributing right now. We're expecting $17 billion more state revenue, though, than earlier projections over the next 2 years from high-income earners, maybe some of you, record Wall Street bonuses, and a booming economy. And booming economies good for everybody. This may sort of come as a surprise to you, but you might be wondering, what radio station does the health commissioner listen to on the way into work in the morning? Like, you're probably wondering, am I listening to The Bridge? I'm on XM radio, like maybe sometimes, but I'm usually listening to Bloomberg. Why does the health commissioner care about finances? Because if you understand New York, you have to understand the economy. And if you think about why public health is public health, a lot of what we're looking for is how does the economy affect people? And so much, like one of the biggest social determinants of health of somebody is a job with health insurance, right? So if you understand the economy, you understand a little bit about public health. So that's part of why I listen to Bloomberg among all the other media outlets there in the morning. These are some of the big proposals. I love universal child care. When you think about affordability, this is one of the biggest expenses for young families. You know, the governor talked about how she stopped working for a period of time because she had to take care of her kids. My wife did the same thing. At some point, though, she had to go back to work. And just she loved our kids. This was just too much, right? And then safer streets and communities. When you improve public safety, you improve the public health. Protecting kids. Social media, you know, I don't know what the right age is to start your child on social media. I think that's the wrong question. I think the right question is, should my child be on social media? And it's interesting, you might be wondering, what does the Commissioner of Health read in his spare time? Like, what are you reading right now, right? I'm reading a book called The Anxious Generation by Jonathan Haidt, which talks a lot about just how smartphones have changed the way children's brains develop, how children grow up, and why we have something called the anxious generation. Social media plays a part of it. I'm not saying social media in and of itself is evil. I'm on Facebook because that's what old people like me do. But I do think it's important to know that when children are on social media, this is a very big step, and I don't know that they're developmentally ready for that. Very interesting. So there's a lot of nice proposals in this budget about blocking direct messages from would-be predators, disabling artificial intelligence chatbots that target minors, and strengthening youth mental health care. Very critical concepts here. And just interesting, I don't know if you guys remember your adolescence. Mine was a long time ago. I had a hard enough time without, it was a struggle, but like, I didn't have this. And there's a reason why kids are ending up the way they are, so this is very critical. And then defending fundamental rights, protecting youngsters from government overreach, safeguarding due process, ensuring no one is targeted or mistreated simply for who they are or where they come from. Quite frankly, I do not know what an American looks like. I don't think you do either. And it concerns me that we see what's going on in our country where some people seem to think they know what an American looks like. I'm very disturbed about what goes on in Minnesota. I think anyone who's got a conscience should be very concerned about it. I have colleagues in Minnesota. What I hear from my colleagues is they walk around with their papers. They live in a state of heightened anxiety. It's traumatic for everybody. People are afraid to go to the store. Kids are afraid to go to school. It is really very deeply concerning to me. I'm going to talk mostly about healthcare in this budget because I'm the health commissioner. Right? So it's funny. I think as a leader, I sometimes tell my team I do two things. I have really two main jobs at the University of Department of Health. My first job is to make complicated things simple. That's really what I do, to make complicated things simple. The second thing I do is I point out the obvious. It's really what I've reduced my job to. So I told you, $260 billion budget, $111.9 billion is my budget. So I'm the size of a Fortune 500 company, just in case you were curious. I do not have a corporate jet, nor do I have a driver. I'm just a guy who drives a Subaru, right? But this is who we are, right? Here's my Medicaid budget, $99.9 billion. This is where I point out the obvious. This is what should concern you. That $3.8 billion from the Essential Plan used to be $13 billion. What H.R. 1 did to us was cut our Essential Plan budget by a lot. When I say I point out the obvious, this is what we call the public health problem. When you wake up in the morning and find $10 billion less, that's something that's a really difficult hole to dig out of, but we have a plan to do that. And I'll talk a little bit about that. But I think part of what you look is like health program enrollment. 6.8 million Medicaid enrollees. During the height of the public health emergency, it was 8 million. So we've made progress here. 1.7 million Essential Plan enrollees, 550,000 Children Health Plus enrollees, 38.2 billion, 11.4% Medicaid year increase. That's the state share of Medicaid. So in other words, Medicaid went up 11.4% from us. No one's getting an 11.4% raise. That's not how it works. If you're wondering where does Medicaid spending go, think about pharmaceuticals, long-term care, whatever that looks like. Those are the biggest drivers of Medicaid increases. But this is one of those things where Medicaid is the biggest part of the state budget. So in other words, $99.9 billion of a $260 billion budget is just Medicaid. I have a lot to manage. Medicaid's a big part of our portfolio. The Affordable Care Act is something that's near and dear to the room. So let's talk a little bit about it. We started this in 2015. We opted into the Essential Plan. This was a brilliant move on the people who were in New York before me, right? Opting into this was brilliant. It was a really good idea. One, we insured a lot of people, but the way we did it really helped New York financially for the future. 1.7 million New Yorkers have access to health care at no cost. But the Essential Plan is commercial level health insurance. You know, everybody likes it, right? Doctors like it, hospitals like it, really good health care, and you have no premium. You might have a few co-pays, but really no premium. Due to the H.R. 1 cuts, New York State has submitted a request to terminate the waiver and revert back to the basic health plan. For those who are into details, we are terminating our 1332 and reverting back to our 1331. My gosh, that's confusing. What we're doing is going back to what's called the basic health plan. We have to do that. But we're waiting for permission from the Center for Medicaid and Medicare Services to do that. If we didn't do that, we would lose it all. You just can't flout, federal law. You can't, financially or legally. But that's going to preserve coverage for 1.3 million people. So the basic health plan is limited to twice the federal poverty limit, 200%. So 450,000 current enrollees would become ineligible for the essential plan. That means they're going to have to get what's called a qualified health plan. There might be a subsidy, but now there's a premium. Part of what I want to talk about with that is we actually opted into 1332 by allowing people up to 250% of federal poverty. That was a real win for working New Yorkers because more people got really good health insurance and we're saving like roughly $6,000 a year. Real money, real important. But the qualified health plans are insurance, right? And there is federal premium tax credits, but it's not as affordable. The problem we're running into, and this is really one of the concerns I have about this, is when you think about qualifying for this is discretionary income. But when you live on the amount of money we're talking about here, you don't have a ton of discretionary income. So you might be forced with making choices about whether or not you're buying food, whether you're buying shelter. It's tough. So this is a really difficult thing that the federal government did to us here. It's very concerning. Having said that, let's move on to some of the investments. The Safety Net Transformation Program, we started this a couple of years ago. It's really a way of helping hospitals find a sustainable future. Like one of the things about New York State, we've been in a very interesting situation for the last several years, even before the pandemic, as hospitals needing government subsidies just to exist. What you're finding is healthcare is moving so fast. In order to stay competitive in healthcare, it's really hard to do it as an independent entity anymore. Healthcare is extremely complicated. So really what we're looking for is safety net transformation. In other words, a hospital that's in trouble transforming itself by partnering with someone who's not in trouble. Healthcare, if you can run operations at lower overhead, you're more likely to be safe for the future. One of the things I've seen about hospital leadership, there's some that do it well and some that don't do it well. If you don't do it well, that becomes problematic for everybody. There's other reasons why hospitals aren't succeeding, but healthcare leadership is really important. There's $1 billion for capital funding and $330 million for operating funding in this year's budget. There's $1.2 billion in the managed care organization tax revenue disbursements. This will help with healthcare facility transformation, help with providers, help with hospitals, nursing homes, assisted living. And there's $750 million in new resources for hospitals and nursing homes. So some of this money will be passed on in the form of operating revenue. Immunizations, big in the news this year. It's interesting, we were counting on the advisory committee of immunization practices to be what they always were. I don't think anybody really thought what's going to happen actually happened, where the advisory committee was basically summarily dismissed for no reason, and then installed with people who just quite frankly didn't have the same expertise. So there's a law that's in the legislature right now that would really put the authority to decide what is the schedule of vaccines and what are the best vaccines to get in the hands of the Commissioner of Health. The Commissioner of Health would rely on not just the advisory committee, but American Academy of Pediatrics, American College of Obstetrics and Gynecology, American Academy of Family Physicians. In other words, there's just some safeguards in there because I'm not going to be in the office forever, but just to make sure that our immunization schedule is divested from the federal government. This is probably a good idea anyways, because generally you shouldn't be ceding power as a state to the federal government if you don't need to. But there's a really important piece of legislation here that the governor introduced as part of her state-to-state initiative that I think is really important. The changes in the immunization schedule that occurred federally have no impact in New York right now. I think it's important to caveat that. States decide the schedule. States decide what are the vaccines that you get and what is mandatory for school entry. That's what states decide. What happened recently was the federal government changed the CDC schedule. Just important to put that out, the CDC did not change its schedule, the federal government changed its schedule. Why it's an important caveat is there wasn't new information, there wasn't new safety data, it was just changed to reflect Denmark. And it's created a great deal of confusion outside of New York and to some degree New York, but this would help to clarify things like that. And then removing unnecessary restrictions for healthcare workers. One of the things that's near and dear to us is scope of practice. Well, in other words, training people to do something and then not allowing them to do it, that just doesn't make sense. Working at the top of your license, working at your highest level, this is not new information. This is something most states have embraced decades ago. It might surprise you that New York State's the only state in the United States that doesn't allow a medical assistant to administer a vaccine. So in other words, 49 states have said a medical assistant give a vaccine. New York hasn't signed on to that yet. We're hoping that'll get done this year. They got close last year, went through the Assembly, did not make it through the Senate. Physician assistants with sufficient training to practice independently. Certified nursing assistants could administer medication in nursing homes. 38 states allow that to happen. New York hasn't signed on to that. But when I go to nursing homes, one of the things I hear all the time is they just can't find nurses. We do have a nursing shortage in New York State. One of the problems with, it's not that we're not training a lot of nurses, we are. One of the challenges is only half the nurses who are licensed are actually in direct patient care. Now, lest you think that's a reflection on nurses, it's really more a reflection of a nursing degree. It's a very good degree. If you have a nursing degree, you can go a lot of places, do a lot of things. If you look at who's running healthcare, a lot of times it's someone who started out as a nurse. If you're looking at who's in government, a lot of times someone who started out as a nurse. If you look at who works in the health department, it's a lot of times it's someone who started as a nurse. In other words, nursing degree takes people a lot of places. So we train a lot of nurses, but one of the challenges we're having is we aren't, letting people who aren't nurses do what we know they could do. There's access to medical care for injured workers. Let injured workers see the doctor they trust. We really revised workers' compensation a little bit to end some of the outdated red tape. Extend access to licensed providers in good standing, and fix delays that cause a system that authorizes only 10% of eligible workers. And then cut wait times for more travel. Really so people can get back to work sooner, and that would take effect in January of 28. Other things, expanding use of artificial intelligence in healthcare. This is inevitable. It's not like this is new. Artificial intelligence is happening. If you have a smartphone, you're using artificial intelligence. If you're on Google, you're using artificial intelligence. It's happening in healthcare. What we're doing is hiring the expertise in my department so we can help manage it. And really it's about putting a consortium together so we can really see what is going on in healthcare in New York State. We're not trying to regulate it, quite frankly, we're just trying to understand it. I have people who understand artificial intelligence in the New York State Department of Health. One of the things we've done as a state agency is we do use artificial intelligence, but we're very deliberate and thoughtful about how we use it. In other words, just because you work for the New York State Department of Health doesn't mean you can start using artificial intelligence. We have to know what you're using and why you're using it. Because artificial intelligence is a tool, but if we don't have vetting on it, we don't know what you're doing, we don't know if it's actually going to introduce bias or harm. And I need people to be in between that. That's one of the biggest things I see right now with artificial intelligence. Right now, it needs a human being involved with it. So it's inevitable, but we're just trying to see how we can do this and make sure that we use the tools the best we can. And there's definitely utilization for it though. And then food assistance became more and more of an issue in the last year. I don't know how many people know we have something called the Hunger Prevention Nutrition Assistance Program and Nourish New York. They're different programs. Hunger Prevention Nutrition Assistance Program, simply put, we contract with 10 different regional food banks throughout New York State. They subcontract the thousands of soup kitchens, shelters, and food pantries. Really, it's about distributing high quality, nourishing food. There's a lot more money invested this year. Our HIPNAP program budget at the end of the year will be $72.5 million, which is a very substantial increase, more than double. And our Nourish New York program will be $55 million when all is said and done. Nourish New York, in case you're curious, I do that with Ag and Markets. That just takes New York grown food and gets to the hand of New Yorkers. It's just that simple. Whether it's milk, cheese, or anything else we grow in New York, maple syrup, you name it, we have it. But these are really important. These aren't the only nutrition programs we have. We administer the Women, Infants, and Children program, the WIC program. That's a $623 million program. The WIC program, though, is a different program, and that's not the same as Supplemental Nutrition Assistance Program. But this really gets into why the Hunger Prevention Nutrition Assistance Program is so important. One of the things about regional food banks and just food banks in general is, boy, your dollar goes far there. They know how to buy food. They really do. They know how to put food in the hands of the right people. And I think, one of the things we tried to do this year was destigmatize a little bit of who goes to a food bank, quite frankly, because people go to a food bank when they need to. And I think it's just really important that they're supported. One of the things that's also there too, like, gosh, the penchant for acronyms sort of stuns me. New York Plates. I don't even know what PLATE stands for, and I'm not sure why they just didn't call it what it was. It's capital funding for food banks. So there's $10 million for capital funding for food banks. So you might think, what do food banks need to buy, right? Well, freezers, refrigerators, warehouses, the type of things. So $10 million is going to help food banks to expand in that kind of space. This is me out in Syracuse, the food bank, and quite an operation out there. A lot of investment in water this year. A 5-year, $3.75 billion commitment to clean water infrastructure. I do a lot of this with Department of Environmental Conservation and the Environmental Facilities Corporation. This is where agencies work together to administer this. There's $23 million in the Clean Water Improvement Act funding to assist in replacing service lines. And then in 2025, one of the things we did was implement the lead rental registry in New York State to ensure homes are safe for children and free of lead. This was a 2-year project. Really proud of the team for getting this done. 25 of the highest risk counties in New York State. But what we've been doing in New York, is what occurs throughout the rest of the country, is you check lead levels in children, babies, right? Toddlers, year-olds, right? That's still something we're going to do, right? But in case you're curious, in 2010, roughly 17,000 children in New York State had a blood lead level over 5. Keep in mind it needs to be 0, right? Well, last year it was 7,000. Oh, great, 58% decrease, but we're shooting for 0. Kids get exposed to lead often, though, from the place they're living in. So what the lead rental registry program does is, if you're someone who rents property in one of these 25 counties, every 3 years you have to have a lead inspection. If you have lead in your home, there's $20 million available through another state agency that you can access to some of that lead remediation. Paint's one of the biggest drivers, even still, but there's some other drivers of lead in people's homes. So a really nice public health problem. And the thing about lead poisoning prevention is there's nothing I can do once someone's got lead poisoning except help get rid of it, but the damage is done. Universal pre-K is a big issue in New York State. Wonderful to see kids get to school at age 4, getting there at no cost. It's a great thing. And so love this initiative as well. And then a little bit more, $4.5 billion statewide investment for childcare and pre-K. One of the signature initiatives of this year's budget. $1.7 billion is in new investment statewide, over $3 billion in childcare vouchers statewide to address waiting lists. $500 million over 2 years from New York City's 2 care program. So really nice investments. I think a lot of this offers parents who are looking for, quite frankly, affordable childcare to actually achieve affordable childcare. So taking one of the bigger expenses literally off the table and onto the budget. This is really probably one of the biggest drivers of affordability in this year's budget. One of the ones that you might think, why does the health commissioner care about this? Well, if I make life more affordable for you, I decrease your stress, let you spend money on things you want to spend money on, and it really does seem like it's a public health win to me. And these are social determinants of health, right? Like you think about health, right? Health care is important, but we know that your overall health is really improved by things like where you went to school, did you live in a safer neighborhood, do you have transportation, what's your socioeconomic status, what's the language that are people speaking to in that language? These are all social drivers of health. It's the social determinants that really improve your health and well-being. All right, questions. That's the most important time. And I will take a sip now of my Adirondack water, just so you know I'm from upstate New York. Thank you. A little hail of the Adirondacks here. Thank you so much for that. All right, who's got questions?
Okay, who's got a question? Yes.
You had mentioned practicing at the top of your skill level, whatever. I actually was networking online yesterday with somebody from Florida who said, I do mortgages. I said, where? She said, everywhere in the country except New York. And then I talked to somebody who is in Texas who does life insurance and says, I couldn't work in New York. It was too complicated. Are these sort of initiatives to open up to make these the regulations around doing business in New York just going on in healthcare, or is Hochul, do you know if this is a more general attempt to make it a little bit easier to do business here?
I think New York is complicated too. So I can't speak to those 2 professions, I can speak to healthcare, but I think you're hitting the nail on the head, which is when you have a restriction on someone's ability to do something, really why is that there, right? Like in my, just so you know, I came from Rhode Island. I'm from upstate New York, but I was in the Rhode Island Department of Health for 10 years. I ran a state medical board for 10 years, right? Plus everything else I did there, right? I think I know a lot about scope of practice for physicians and PAs and quite frankly, anybody. But when you think about issuing a license, it's iterative. If you meet the qualifications, you get the license. But why do we actually limit anybody doing anything? It's to make sure you're safe to do it, right? When you think about what is the role of a state government, it's are you competent and safe to do it? And just want to kind of answer your question. What I'm looking for is competency to safely do a skill. I know a medical assistant can be competently and safely trained to administer a vaccine. During the pandemic, do you know the training of who gave you that COVID vaccine? Are you sure it wasn't a custodian at the time? Did you care? I'll let you know this. During the pandemic in Rhode Island, we actually offered a training to anybody to become a vaccine administrator. It was an hour-and-a-half training. We could teach anybody in an hour and a half, and I mean anybody, to administer a vaccine. It is not hard. And by the way, medical assistants, just in case you're curious, can draw blood. That's a skill. By the way, they can do an EKG, which that you can screw up, but that's a skill too. they can do other things too, but I think to your point, what I'm looking for as a skill set is competency. What I worry about sometimes in every state is protectionism. One of the things about healthcare in particular is the healthcare pie is so big no one can eat it. We have no space for protectionism in healthcare in New York State. And that's really what I think we've been fighting against. Because you think about why certified nursing aides are giving medicine in nursing homes, right? You might wonder, can a certified medication aide give medicine anywhere in New York? Well, they can in an office of people with developmental disabilities home. That's odd, you know what I mean? In other words, this is really getting away from protectionism more towards like who can competently do it.
George.
Yeah, Commissioner, so you mentioned something about safety net hospitals. 2 weeks ago, I was in Brownsville, Brooklyn, and I had a meeting with the president of Brookdale Hospital in Art Gianelli. And they were telling me, I work for M.P.H Health, the health insurance plan, that they would like to do some type of partnership with us around safety net hospitals. And I really didn't understand it. They were trying to explain it to me, and now you've just mentioned the program that they have for safety net hospitals. For those who don't know, safety net hospitals are hospitals where people with Medicaid or uninsured go to. An awful lot of Medicaid people, they're really the poorest hospitals that don't receive enough reimbursement from payers like ours, I guess, but mostly commercial, not the not-for-profits. They don't receive enough reimbursement in order to make ends meet. And so you just mentioned that. Could you spend a moment to share with a little about that?
So the definition of a safety net hospital, they have the payer mix, they have a Medicaid rate higher than 36%. So in other words, more than 36% of their patients are on Medicaid. With the Safety Net Transformation Fund, what we're saying is you have to partner with somebody else. And what they might have been saying to you is, could you partner with a payer? And the answer is, you could. So in other words, you could be the safety net partner. In other words, you have to see how that would work. There's an application process. We do rolling applications. There's no deadline. Usually what people do is send us a letter of intent, then we evaluate it. But we've already awarded 14 different safety net contracts already this year. And it's a little over $4.6 billion. But really what we're looking is sustainable transformational change. Is what we're really trying to do is find a way to take vicious cycles and turn them into virtuous cycles. And that's really what the Safety Net Transformation Program is about. But the partner can be an outpatient one. Like one of the partners we had here was, gosh, they're in the Bronx, St. Barnabas, partnered with an ambulatory care clinic. Chance for them to build a new ED, solve some of their problems, but also for the ambulatory clinic to help with some of their offloading of mental health and improve their behavioral product service line. So nice partnership. There was another hand that was raised.
Yeah, so I have two healthcare facilities in that area also. So they could partner with them.
And we do spend money.
Like what you're talking about with St. Barnabas.
Yeah, and we do spend money in Brooklyn. We've spent $4 billion in Brooklyn since I've been commissioner in 23, but we're not afraid to spend more. So they want to apply, we're interested.
Sorry, I would really like to
Excuse me.
follow up on George's question.
We'll get to you.
Okay.
Yes.
Hi, Commissioner. I wanted to ask about the biomarker testing coverage changes for Medicaid in the budget and what concerns you were trying to get at by using that.
It's more of a clarification than anything else. Like with everything we do in Medicaid, there's an internal review, external review, and then we decide, that we pay for it. What we're finding with biomarkers is there's tests that, although they've been cleared by the FDA, there's really no reason to believe they'd be effective. So it's really about clarification so that we're transparent about the process we're doing. But we obviously know biomarkers are important. That's what it's all about. It's really about being transparent with the legislature about, because the legislative intent wasn't crystal clear for us, but it's really more so we're on the same page. Here are examples of what we don't think we should pay for. Here's examples of what we should pay for. This will be part of the budget conversation. So I think in the end, everybody should be okay with it. We just don't want to spend money on tests that have no value. That's not good for anybody.
Yes, sir.
Commissioner, so was there anything in the budget to try to revitalize rural health in upstate New York, and as far as also attracting any kind of private practices to actually go into rural health? Because it used to be everybody had a country doctor, everybody had the local doctor in every town, and you don't have that anymore, right? So you lose that intimacy with those providers. Is there anything in there, like planning-wise, to try to get that going?
I was a country doctor. I think I still am in Mark now, but the answer is yes. So if there was a virtuous part of HR 1, it was the Rural Health Transformation Program. Emphasis on the word program, not grant. It's a cooperative agreement. So we got $212 million for that. The short version of that is what we'll be doing in rural New York is replacing vicious cycles with virtuous cycles. One, we have money allocated for this, but like one's a workforce initiative to attract workforce in rural New York. But just so you know, in case you're curious, I have 24 different healthcare workforce programs in this budget, almost over $400 million. But there's one specifically for rural workers in New York. One of the other things that's in this is encouraging patient-centered medical home in New York. Is that happened to a lot of practices. You have to get NCQA certification, but we have funding to help rural practices get NCQA certified. Why that's a nice little win for them is, remember, I always like to replace a vicious cycle with a virtuous cycle, right? Replace badness with perpetual goodness. Once you become an NCQA certified practice, I can pay you more per member per month, and I want to pay you more per member per month, but I need that seal of approval, because I know you're getting higher quality care to your patients. But there's also technology investment, but it's $212 million. Now, did I mention it was the most virtuous part of HR 1? Did I mention there's a poison pill in it, though? Let's talk about the poison pill. So if I do not get from the legislature the procurement flexibility I need, this was the poison pill. For whatever reason, the way they wrote this was you have to spend each year's money by October 30th. So if I have to adhere to every single part of state financing law, I will spend none of this, and none of this will happen. So one of the things we brought to the attention of the legislature this year, we need a partnership on it, is I need the procurement flexibility. And if I have the procurement flexibility, then it's on me to go spend the money. And I know how to spend money, but I need that procurement flexibility. And I don't know why that poison pill was put in there. My guess is they didn't really want to authorize this spend in the first place and had to just get the whole thing across to keep somebody from Alaska happy. And Alaska did really, really well on this, by the way, more than anybody else. Take that for what it's worth.
Okay, we'll finish up here.
Thank you. I work for a healthcare contractor. That's all we do is healthcare. So my question to you is, how much of your budget is allocated to building or modernizing or fixing the local hospitals in New York State? Is there a way, it's a three-part question, is there a way to find that information, where that money is being allocated, and do you allocate any to private institutions?
So I don't know why New York State budget law is so confusing, by the way, but let me just share this with you. This is my fourth budget I'll be doing, but in case you're trying to read New York State budget law, you have to go to no less than 4 places to find the law. You have to find the capital investments, because you asked where to find it, right? Then you have to find operations, then you find aided localities, then you read the health and mental hygiene bill, which is all the Article 7s, the governor's proposals to save money through policy change. You asked an honest question, which is like, is there money? The answer is yes. Can it be applied to someone who's private? The answer is yes. However, where is that money is what you really want to know, right? So, safety net transformation investments, there's money there. There's also money we're going to be doing for operating expenses. But the simplest place to look is the safety net transformation program. That's got the most money. There are other little pots around there, but that's where the most money is in the safety net transformation program. And private entities could take advantage of that. They'd have to find a partner, though. And since hospitals in New York are a non-profit, you'd have to probably find a non-profit partner. It's a very honest answer to what seemed like an honest, simple question, but it was not. It was complicated.
Okay, up front again.
Hi. Besides for childcare, is there anything else allocated towards specifically women's health? For like example, women here, 6-month wait for mammograms, unable to get proper testing done for, right now, perimenopause, why was I having hot flashes? I couldn't get that proper testing here in New York. I had to actually pay out of pocket to get done in Florida. And these are things that are happening to a lot of women. I broke my knee a few years ago. They had to give me a brace for a man because for over 8 months they said they didn't have one to properly fit a woman. And I understand that's private, but is there anything, because we're all dealing with this in here, women, I think we can all agree, is there anything allocated towards specifically that, you know, how to get more mammograms, testing facilities as such for specifically women?
So in this year's budget, a couple things. One is, so we spent roughly $2 billion on maternity care. You know, what you're talking about, there was a larger access to care problem. And so there, you asked an honest question, here's the honest answer. There's $100 million for reproductive health to deal with changes from the federal government. So that's a reproductive health investment. That's not what you're looking for, though. What you're looking for is access to care, right?
Mhm.
So that's part of my 24 different programs in healthcare workforce investment, is what you need is healthcare workers. Like one of the things you said to me was you had to wait too long for a mammogram, right?
6 months on average for
Right.
addressing it.
But that's not because you don't need a doctor. The bottleneck isn't the doctor to read the mammogram. The bottleneck is the mammogram technician, right?
Yep.
And the bottleneck is just healthcare workers. So the 24 programs that I have, and I will not list all 24 from you, I carry that as a list with me. But we actually are training people to go into healthcare starting in high school. Some of that's through the Career Pathway Training Program, through the Workforce Innovation Organizations that was part of the 15 Amendment. But there's all these different programs. We have another area health education center. We are trying to do one, we have diversity in medicine program that's now called the Associated Medical School Program for Science and Public Health. But like, we are trying to bring medicine to become more, healthcare to be more diverse. Because quite frankly, one of the things the federal government did, they didn't broadcast it, was they seem to think they want a healthcare worker to look a certain way. We don't like that. They quite frankly ought to be ashamed of what they're doing. They've done some things with student loans they found objectionable as well. But we're doing not just to increase just healthcare workers, but also to bring people to healthcare who want to be in healthcare and trying to improve the diversity in healthcare as well. Because quite frankly, one of the things I'm struggling with is there's a lot of people who would love to have a job with health insurance and sleep well at night. That's a job in healthcare, quite frankly. Night might be you work the night shifts, you go to bed in the morning, because we do work 24 hours a day. But there's, one of the things about job in healthcare, you have health insurance and you go to bed at night knowing you did some good for somebody else. It's a good thing.
I know the commission has a very busy schedule. I don't know if we have time, or maybe we should have people come up and ask you one-on-one now.
I don't know, Mike, what time is it that I have to go next? You're keeping track of that for me, right?
I've got a little bit of time.
Like a little bit of time. So what's a little bit of time in real time?
It's like, about 12:30.
I have to leave,
Okay.
I have to leave in 10 minutes.
Yeah,
So James Kim, he runs the Korean American Chamber of Commerce.
We go way back.
Right. On the screen, I saw the federal budget by 11% something, right?
Well, there was 11.4%
Right.
increase.
How would it affect the financial operation of the state?
So the state, through its division of budget and the governor, have found a way to mitigate all the federal losses. So in other words,